Good afternoon. Oh, I'm pretty loud, I guess. I'm Craig Myers, and I've got the honor of introducing our next Hanny Scholarship winner, Maggie Sawyer. She graduated from Laura High School in Boise, where she was a student athlete. She received many academic and leadership awards while participating in basketball, golf, and swimming. She's a senior here at Willamette, and she's continuing that tradition of being a student athlete. She's a senior exercise and health science major with minors in chemistry and biology. She's been a member of the Bearcat basketball team, and currently, although their season just ended, she was on the softball team listed as a utility player, which means that she could play a lot of different positions. In addition to all that, Maggie works as a student athletic trainer and a biomechanics tutor. After graduation and a gap year, she plans to attend medical school. In her free time, she enjoys being outdoors, specifically hiking and camping. Please join me in giving a warm WICL welcome to Maggie Sawyer.
Hi, Craig. Thank you for that introduction. I just want to take a moment to thank the Hanny Scholarship Award Committee for picking me to be a finalist here, as I'm really excited to share this original research project, and I'm really proud of the work that I did for it. And I want to thank you all for being in attendance today, listening and learning about the influence of breast tissue on the motion of a shoulder in healthy women. So before I begin, I just want to define a couple of terms. This first one is, what is a scapula? The scapula is commonly known more widely as your shoulder blade. It's one of the main bones that makes up the shoulder joint. So the shoulder joint is a ball and socket joint. We have what's called the glenoid fossa of the scapula. That is known as the socket of the ball and socket joint, pictured there on the left side of the screen, where it meets the head of the humerus, which is the ball part of that ball and socket joint. It meets up right there, shown here on the right side of the screen. That's what is known as your shoulder joint. It's also commonly known in the scientific literature as the glenohumeral joint, because the glenoid meets the humerus. There's two other things that I want to point out on the scapula before we begin that I will get into a little bit later in this presentation. The first one being the top part of this bone that protrudes out forwardly on the scapula. It's known as the acromion process. And then this next one here, this lower one that goes forward, is known as the coracoid process. So I have a couple scapulas that I'm going to pass out today, so you guys can all look at them, play with them. The way that the scapula would be oriented in the body is it would sit kind of like this. The glenoid fossa points outward toward that side, so I have this one is a left, where this one would be a right. So I'll pass the left side out here. Go ahead and pass that around, play with it. Oh.
Are these life size?
This one is an actual bone. I did something. Came back. Magic. Okay. So that one's a little bit bigger, but it depends on the person. It can be life size. The next thing I want to talk about is kinematics. So as you saw in my title, the word kinematics was in it. Kinematics, from a biomechanical lens, or the lens through the human body, is the study of motion, specifically how the body moves through space and time. So when we apply this to the scapula or the shoulder blade, we're talking about many different motions that the scapula can have. But the two for my presentation that I'm going to be focusing on are on this left side of the screen in this big red box. The first one is upward and downward rotation, and the second one is known as scapular tilting. So for upward rotation, as we elevate our arm, your scapula will naturally rotate upward to help accommodate for that motion. This needs to occur because if your humerus is just moving in the joint, it can run into this bone up here, so the scapula rotates upward with it to allow full range of motion. So upward rotation is the scapula rotating upward as your arm elevates. Downward rotation is the scapula rotating back down as you lower your arm back down to your side. The next motion is scapular tilting. So the scapula can sit, this is looking, if there was a camera here pointing this way to my shoulder, that's what this view would be, and that's the same view in this image. When this acromion process that I pointed out earlier moves forward, that's known as anterior or forward tilting. Additionally, another way to think about it is we have this inferior angle, this point here, when it points out. This moves forward and this goes backward. That's anterior tilting. Additionally, we have the opposite of that motion, backwards or posterior tilting, where it moves this way. Another way to think about it is if you're able to, you put your arm behind your back and you can observe your neighbor or the person next to you. Their inferior angle should be sticking out. So for me, you can see right here it's sticking out. That is an anteriorly tilted position within your body. So now let's get back to my research project and why did I choose to study this topic? Well, it all started 2.5 years ago when I was in my advanced anatomy class with Professor Lucas Ettinger in the back over there. We were learning about a deep dive of the shoulder anatomy, and we were talking about a shoulder disorder, specifically impingement, which I'll talk about in a little bit. And we were learning how there's a specific population that is seeing a high prevalence of this specific shoulder disorder, and it's something that piqued my interest because I personally have had multiple shoulder injuries resulting in 2 shoulder surgeries, and I was diagnosed with this impingement. So it's something I wanted to understand a little bit deeper, so I brought my interest to him and we talked about it, and we were talking about how there's not a lot of literature explaining the connection between this prevalence to this population, and this population happens to be breast cancer survivors. So 317,000 women in the US alone were diagnosed with breast cancer just last year. Worldwide in 2022, I think 2.3 million women across the whole world were diagnosed with breast cancer. I wasn't able to find, we don't have the worldwide data yet for the year 2025, so I used the US number. And of breast cancer survivors, 68% experienced some form of shoulder dysfunction. So this is that connection that Professor Lucas Ettinger was talking about and piqued my interest of why is it that this population is experiencing this. So that means that 215,000 about experience some form of shoulder dysfunction of those breast cancer survivors, all as a result of getting breast cancer. So one of the most common forms of shoulder dysfunction is subacromial impingement syndrome, where 46% of all doctor's visits related to the shoulder are pertaining to subacromial impingement syndrome. In other words, all the patients that go to their doctor complaining of shoulder pain, 46% of them are diagnosed with subacromial impingement syndrome. And subacromial impingement syndrome specifically is the highest secondary morbidity to breast cancer survivors. But what exactly is subacromial impingement? Well, on the scapula going around, or if it's stopped, we have the acromion process. That space below it is known as the subacromial space. This space is important because there's a structure known as the supraspinatus tendon that runs through it, and this tendon is one of the rotator cuffs. If you're familiar, there's 4 muscles to the rotator cuff that all work together to stabilize the shoulder joint, specifically keeping your arm bone within the socket of the scapula. And when this subacromial space becomes shortened, it can cause pinching, entrapment, or compression of this supraspinatus tendon, which results in inflammation or even in severe cases, tearing of the tendon. This results in anterior shoulder pain when elevating the arm. So 2 motions, those 2 motions I was talking about earlier, upward rotation and anterior tilt, or scapular tilting, reductions in upward rotation, meaning you're elevating your arm and the scapula is not going upwardly rotating as much as it should be, is associated with subacromial impingement syndrome. Additionally, anterior tilting is associated with subacromial impingement syndrome, where posterior tilting is associated with healthy mechanics of the shoulder. So Horstat and Sukes in 2012 wanted to study the high prevalence of breast cancer patients being diagnosed with subacromial impingement syndrome. So they did a study where they were looking at the scapular kinematics, or the motion of the scapula, pre and post a unilateral mastectomy. So they recruited patients who had breast cancer just on one side, so just in one breast, and they underwent a unilateral mastectomy, and they measured the scapular kinematics, specifically upward rotation and anterior tilt. But I'm going to be reporting the data for their anterior tilt, where they found that removal of the breast mass resulted in a 3.1 degree reduction in this anterior tilt. So after the breast mass was removed, we see the scapula go from this anteriorly tilted position to a more healthy tilting position. However, when we compare this to their unaffected side, we still see a 3.5 degree difference, meaning that that affected side where we saw the reduction in tilt is still 3.5 degrees more anteriorly tilted compared to their side that did not receive breast cancer. This means that something more than just the breast tissue could be playing a role into the differences in scapular mechanics that we see, but the large mechanism is largely unknown in the literature. No studies have previously looked at the specific influence of breast tissue on scapular mechanics. So why is it that a breast could even be influencing this scapular motion? Well, when we look, the breast is non-contractile tissue that just rests, and it's enlarged in women, and non-contractile means that it cannot generate motion on its own. But when we look closer at the connection of a breast to the chest, we see that it's connected to what's known as the pectoral muscles through a network of fascia called the pectoral fascia. One of these muscles in particular, the pectoralis minor, connects directly to the scapula on that coracoid process that I was talking about earlier, here, this second lower bone. This muscle has been shown previously in the literature to influence the movement of the scapula. In a study where they looked at short versus long resting lengths of this pectoralis minor muscle, they found that having a shortened pectoralis minor can cause increased anterior tilting, or that forward tilting of the scapula, where at higher humeral elevation angles, such as 90 degrees of arm elevation, that'd be about here, they saw a 6.8 degree mean increase in anterior tilting between that short and long group. Additionally, that was further increased at this higher humeral elevation angle of 120 degrees to a nearly 10 degree increase in anterior tilt. So we see that the breast is connected to it. It's possible that due to gravity, it could be pulling that pectoralis minor into a shortened position, ultimately influencing the motion of this bone. Additionally, women commonly support their breast tissues by wearing a brassiere, more commonly known as a bra. In a study where they compared a bra-wearing condition to a non-bra-wearing condition in the same participants, they found that just by wearing a bra, we can see that upward rotation is reduced. On the left side of the screen here, the blue line represents wearing a bra, where the red line represents not wearing a bra. So we can see that the red line on the left side of the screen has higher degrees of upward rotation, where the blue line has lower degrees of upward rotation. The upward rotation was reduced by about 10 degrees just by wearing a bra. Additionally, when we look at the right side of the screen, bra wearing condition is still in the red line, or blue line, and the not bra wearing condition is still in the red line. We can see that anterior tilting is increased in the bra wearing condition. So anterior tilt is the numbers on the positive side, where posterior tilting is the negative numbers. We can see that not wearing a bra, we see the scapula going back into posterior tilting. But when a bra is worn, the scapula stays anteriorly tilted, suggesting that wearing a bra can also influence the movement of this bone. However, the extent of this effect has not yet been measured, meaning we don't know how varying masses in a bra can make this effect larger or smaller. So to kind of take the first step in answering this question, Professor Lucas Ettinger and I worked together on a previous research project that we did last summer for SCRP, where we looked at the effect of breast size. So we were looking at cup size to understand, does the size of the breast have an influence on this bone? We found here, you can see the blue condition is the small cup size group, where the red condition is the large cup size group. You can see that there's not very much difference between those groups at each of the humeral elevation angles, but when we do compare this data, it is showing healthy scapular mechanics for both, so it is normal, ultimately meaning that cup size probably doesn't have an effect. But this means that we are seeing that the breast could be influencing the bone, but if it's not cup size, that results in something that gravity could be influencing, such as mass. Leading to my question and my hypothesis, how does varying mass influence scapular upward rotation and scapular anterior tilt within a bra? We hypothesized for this research project that increased mass in the bra would result in increases in scapular anterior tilting and reductions in upward rotation. So to answer this question, I recruited 20 participants between the ages of 18 and 35 across Willamette University who are habitual bra wearers, meaning they just wear bras on a day-to-day basis. This happened to be all female participants. Additionally, they had to have no rotator cuff pathology, meaning no injury to their rotator cuff previously, as well as no personal history of breast reduction, breast augmentation, breast cancer, or previous mastectomies. This study design is a within subject design, meaning I'm looking at the same participant in two separate conditions. So I had to randomize the starting groups that they were in. Group 1 was a no weight starting condition, meaning just themselves in a bra. And then group 2 is a weighted starting condition where I increased mass in the bra, which I will talk about in a little bit. And they started with that condition first. Informed consent was of course obtained before doing any testing procedures on all of the participants, and this research project was approved by the Institutional Review Board of Willamette University. So I controlled for the bra for each of my participants to control for that variable. In order to do this, I first had to measure their cup size to understand what fit of bra they would be. So I measured their underbust and then their bust, seen here on the screen on the bottom. And I used a size chart in the literature from those calculations to determine their cup size. After I figured out their cup size, I then used a size chart provided by the brand of the bra that I chose to determine whether they'd fit into a small, medium, large, or extra large. The bra type that I chose is a compression fit sports bra with straps that are minimal in the scapular region, just meaning that there's two straps that go straight down. There's not straps pulling in different directions. This is to reduce interference with the sensors that I'll talk about in a sec. So to measure scapular kinematics, this image on the right side of the screen is one of my participants with the weight in the bra and the sensors on for guidance. To measure the scapular kinematics though, I use what is known as a Pahema's Fast Track. It's an electromagnetic tracking device that can collect data in the motion of the scapula at 40 hertz, meaning 40 data points per second. In order to do this though, I first had to calibrate them and set them up to the system. By doing this, I had 3 sensors I placed. The first one is on the manubrium of the sternum right here on the chest. The second one is on the deltoid tuberosity of the humerus, so basically the side of the arm. And the last one is on the back, it's on the spine of the scapula here. I did this for the dominant arm of each of my participants. After all those sensors were placed, I did a 3D digitization of the bony anatomy to calibrate each of my participants to the system. So the system was set up specific for each one of my participants. After everything was all calibrated and ready to go, I instructed them to do a series of 3 arm elevations for each condition. These arm elevations occurred in the scapular plane, so when your arm is straight out to your side, the scapular plane is 30 degrees inward. This is just the natural plane where the humerus lines up perfectly with the angle that the scapula sits in the body. So I had them do 4 seconds on the way up and instruct them up, 2, 3, 4, down, 2, 3, 4. And this rate was kept by a metronome, so that way we had a consistent speed for all of the participants. After all the data collection was finished with that, I interpolated the data into a linearized fit of 5-degree increments, meaning I had a data point at every 5-degree increment, starting as little as 0 all the way up to their maximal humeral elevation angle, where I then picked 30, 60, 90, and 120 degrees of that humeral elevation or the arm elevation. So I keep talking about increasing mass in a bra. What I mean by that is I had weights that I chose to insert into the bra. In order to do this, I first had to understand what a typical breast might weigh. I found in the literature that a breast can weigh anywhere from about 0.23 kilograms up to and exceeding 1.8 kilograms. So I chose a weight that signifies a 2-cup weight increase. Here, I'll grab these right here. You can pass them around. These were the weights that I inserted into each bra. So it feels really heavy at first, but 2-cup weight increase means I'm going from an A to a C, or a C to a double D. So that's what this weight signifies. It's about 0.9 kilograms, so I rounded that up to 1. And I used a uniform mass in the form of a sandbag, and I inserted them into handmade loading pouches in each of the bra, where I sewed a pouch where the weight can insert directly into them on each side. To analyze this data and understand what I'm looking for, I used a tool to look at differences. It's called an ANOVA. I ran 2 separate 2-way repeated measures ANOVAs. This is to look at differences based on weight condition, weighted versus unweighted, and the humeral elevation angle, so 30, 60, 90, 120 degrees, and understand where these differences are. I ran one for upward rotation and another one for anterior tilt. I had 20 participants complete my study, all with varying cup sizes. I had the most amount of participants be a cup size of B, with 7 of them, and the least amount of participants with a cup size of D, having 0 of them, followed by double D had 3. 5 participants reported shoulder pain, but on a scale of 1 to 10, nobody reported shoulder pain higher than a 3 out of 10. In those randomized groups that I was talking about earlier, 8 participants were randomly selected to be into group 1, meaning that they started with just the bra and no weight inserted. And then 12 participants were randomly selected to be in group 2, which means that they started with the weight in the bra first. The mean age for all of my participants was about 20 years. The mean height was about 167 centimeters, which is about 5'7", and the mean weight was 71 kilograms, which is about 156 pounds. So for upward rotation, here on the graph, the blue represents the unweighted condition, and the red represents the weighted condition. We found that there was really no significant differences based on weight for upward rotation. But we did find differences based on humeral elevation angle. As you can see, 60 has numbers higher than 30, 90 higher than 60, so on and so forth. But this was to be expected as the scapula naturally rotates upward when we elevate the arm. So that's what those differences at humeral elevation angles signify. When looking at anterior tilt, however, we do see significant differences. We can see that the red, the weighted condition, seems to be much higher than that blue unweighted condition. So increasing the mass in the bra, we see differences and increases in anterior tilt. We also see differences based on humeral elevation angle, meaning that at higher humeral elevation angles, we saw larger increases. At 90 degrees was our largest increase of 6.27 degrees. So that means our unweighted condition, we have the scapula. You can also look on the right side of the screen, it shows 6 degrees of increase. We have our scapula here, and then we add a weight into the bra, we see the scapula increasing anterior tilt by about 6 degrees. This feels like it's not a lot, but that means that the inferior angle down at the bottom is moving about 2 centimeters. So we are seeing a 2 centimeter shift in this scapular movement. So to recap everything, we hypothesized that increased breast mass in a bra would result in reductions in upward rotation and increases in anterior tilt, or that forward tilting of the scapula. We found that this hypothesis was partially supported, as upward rotation, we saw no significant difference. But for anterior tilt, however, we saw nearly a 40% increase in that tilting degree at 90 degrees of arm elevation, followed by a 27% increase in anterior tilt at that 120 degree maximal arm elevation. So for upward rotation, in order to successfully elevate the arm, we determined that the scapula needs to rotate upward with it to help accommodate for that motion. When we look at the literature comparing women versus men in their upward rotation degrees, we see that women already have reductions in upward rotation. When we look closer at the anatomy of the shoulder and the shoulder girdle for men and women, the only anatomical difference is that women have a breast in the anterior portion of their chest. So that could be why we see those differences, but overall, it's not very well known. Additionally, what we talked about earlier in the introduction, we found that wearing a bra can already restrict upward rotation by about 10 degrees. So it could be that we're observing a potential floor effect where further restrictions in upward rotation past the fact that women already have reduced and then wearing a bra reduces it further, that any more reductions would result in the unsuccessful task of elevating the arm. Additionally, wearing a bra can increase upper trapezius recruitment by 22%. So there's 3 muscles that work together to upwardly rotate your scapula. One of them being the upper trapezius, the lower trapezius, and then the third one being the serratus anterior. So all 3 of these muscles work together to elevate that scapula. And we see that wearing a bra can change the recruitment process. So we're seeing more upper trapezius recruitment compared to those lower and serratus anterior things, recruitment, where more increase in the bra could be furthering the upper trapezius recruitment, creating different muscle recruitment patterns, but overall, this isn't known, so future directions need to look into this to understand. While we could be seeing changes in what causes the force, we're not seeing actual changes in the motion of the bone. For anterior tilt, when we compare our unweighted condition to healthy populations, we see that our unweighted condition exhibits similar scapular mechanics. And then when we compare our weighted condition to those disease populations, we see that those 2 variables are exhibiting similar scapular mechanics. Looking at the disease populations, such as those breast cancer patients and the impingement patients, we see that they on average have an increase in anterior tilt by about 6 to 8 degrees. Our max increase in anterior tilt was 6.27 degrees, falling right in this range, meaning that our weighted data is showing similar scapular tilting degrees as those disease patients, and our unweighted is showing healthy. So this interaction effect that I talked about a little bit earlier, where at higher humeral elevation angles, we see larger differences in those scapular tilting, this follows the trends in the data. As you can see in this graph earlier, I showed it earlier in the presentation, where the bra wearing condition is starting to diverge from that not bra wearing line down at the bottom. So you can see at that higher humeral elevation angle, we're seeing larger differences. Our data followed this same trend where at 90 degrees we saw the largest difference. This could be due to the fact that as we elevate the arm, it's a non-linear trajectory of motion, meaning during arm elevation, the first part of this motion is largely the humerus moving in the joint. And then at about 60 to 90 degrees, we see an important switch from that humerus motion to a larger contribution of scapular upward rotation. At this time, the muscles switch from that rotator cuff and deltoid to scapular rotators, those 3 muscles I was talking about earlier. Increases in load and alterations of recruitment of those muscles can result in decreased stability in the tilting of the scapula, where more load in the bra could be why we are seeing the higher humeral elevation angles having larger differences. But all of the trends in the data follow this trend, and our data follows the same trend, so that raises a question of causality. A classic chicken or the egg scenario, we're all familiar with that. Is it that the alterations in motions in this bone is what is causing subacromial impingement syndrome, or is subacromial impingement syndrome causing those changes in motion that we observe? In a study that looks at rat models where they severed the long thoracic nerve, the long thoracic nerve innervates the serratus anterior, which, while I established is an upward rotator, it's also a posterior tipper of the scapula, meaning it pulls this scapula into considered healthier motions. So paralyzing that muscle forces the scapula to be an anterior tilt. After 4 and 8 weeks of paralysis of this muscle, they found, I did not do this study, they found lesions on that supraspinatus tendon, that rotator cuff tendon, going through the subacromial space, meaning that alterations in scapular movement can lead and cause subacromial impingement syndrome. What this means is that our weighted data is showing motion that can lead and eventually cause subacromial impingement. Some limitations of this study were that I measured the acute effect of breast mass augmentation, meaning I only measured it at one point in time for a short period of time, so it is impossible to tell how habituation to this effect or long-term chronic exposure would change the results that we see, but we can hypothesize that after longer exposure to increases of mass within a bra, we would see reductions in upward rotation. And we can hypothesize that because being in an anterior tilted position places a stretch on the serratus anterior, which pulls this scapula backwards. And according to what's known as the length-tension relationship of a muscle, increased chronic stretch can decrease force of a muscle, overall weakening the muscle of the serratus anterior. And as we established, the serratus anterior is a posterior tipper of the scapula. It's also very important for upward rotation. So if it's weakened, then that means its ability to upwardly rotate decreases as well. So that is why we could be seeing, after long-term chronic exposure, further reductions in upward rotation, probably leading to unsuccessful task of elevating the arm. Additionally, our breast mass was measured externally, so we only increased it not directly in the body due to safety reasons and many other reasons for what I'm able to do with my research here at Willamette. So it is impossible to tell how those natural increases, such as carcinoma, lymphedema in those breast cancer patients, or even increases in breast mass, such as breast implants and whatnot, we aren't able to tell exactly how that could affect this data as well. And last, I controlled for the bra. There are many different bra types in the world, and the literature does talk about how different bra types can have different effects on the motion of the scapula, so we only know that my bra type can have increases in alterations in this movement with increased mass in the bra, so that is another limitation. Some future directions should look into the electromyographic data of those scapular stabilizing muscles. Electromyographic data is just the data that can measure how much a muscle is being recruited. So then we can understand the muscle recruitment patterns that are changing with that increased load within the bra. Additionally, in vivo breast mass augmentation should be looked at to understand how those natural increases in the bra, how those can change our results. But in conclusion, increasing breast mass in a bra can significantly increase scapular anterior tilt, providing a potential mechanical etiology or a mechanism for why we are seeing this high prevalence of subacromial impingement syndrome in the breast cancer patients. And last, women with heavier breasts could be predisposed to scapular dyskinesis and shoulder dysfunction, eventually leading to subacromial impingement syndrome. And this data could provide potential rehabilitative and preventative strategies for these populations that are at higher risk and showing larger discrepancies in their scapular and shoulder blade motion. I would like to thank again the Henny Scholarship Award Committee for the opportunity to present this research here today, as I found this opportunity will be very beneficial for me in lots of ways as I get to share this very important, very new data to the literature and to you guys, to the broader community. And I would like to thank the Willamette Institute of Continued Learning for having me here today and listening for all of this. Last, I would like to thank my sponsor, Craig Myers, for helping me set up for this today. And I would like to thank my advisor, Professor Lucas Enninger, for all of his guidance and expertise in this topic and pushing me to do this research project for my thesis, and the exercise and health science faculty for all of their support along the way. Thank you. And
Hi, as you were giving your presentation, you recorded the tilt angle at a really precise, like 2 decimal points. Could you go into more detail on how you actually measure that angle at that level of precision?
yeah, of course. I'll go back to them. I'm not sure how to do it exactly, but I'll just go back. Okay, so we have the Polyhemus Fast Track. I was saying that it's an electromagnetic tracking device, so it's coded to measure the movement of the bone. You can see here on this participant that we have kind of dots. So the calibration process was I placed these sensors, and then I found anatomical landmarks where I used a wand that is also an it is conductive, so when it's in the field of the electromagnetic sensor, it's able to like send signals to the sensor. So I was able to like place a dot on it was a wand I'd press, and it'd be like, okay, and then it would lock in that dot, and it would tell the sensor this anatomical landmark is this far away from the rest of the sensors. So that's how it would make a map of your body, and then it would, as you are moving, the sensors are able to track those motion, and then it calculates how far away it would be based on where it was in relation during the calibration process. So that computer system, the Polyhemus Fast Track, is doing all that hard work for me. I just had to do the work of calibrating it and making sure everything was right. And we also went through a validation process where I had to have a less than a 3-degree error during the calibration process because it's ran through twice. So I do all the anatomical landmarks 2 times, and then the computer system would be like, okay, that was less than 3% error, it's good to go. And so that's how it would be more precise. The specific like coding and technical things I'm less aware of. There is a validation study that goes into it a little bit more, but that is my knowledge of the sensor system.
Okay, well there we go. This is Cassia. I'm still not clear what effect a forward tilting scapula has. You've demonstrated what it is, but what does it do in terms of your ability to use your arms or your shoulders or any of that? And are there other things that would cause a forward tilt to the scapula besides an impingement syndrome in the shoulder?
Yeah, that's a good question. Thank you for that question. So anterior tilt of the scapula, this subacromial space, imagine my finger is the supraspinatus tendon. As it anteriorly tilts, it can shorten that space, causing the pinching or the entrapment of that tendon. So it shortens that space, leading to injury to those structures running through it. And there are many things that can lead to anterior tilt of the scapula. One is known as pectoralis tightness. So that pectoralis minor muscle, when it's tightened, it can pull that scapula forward and down, leading to more anterior tilt. Weakness of the scapular stabilizing muscles, those muscles I was talking about, including, if you're familiar, you have the rhomboid muscles and stuff. Your back muscles can pull that scapula backwards, so weakness causes it to come forward as well. Does that answer your question? Okay, yeah.
Hi, my name is Joan. Thank you. Would I be correct in saying that one possible conclusion from this research is that finally it was sanctioned that women should burn their bras?
Yeah. I mean, you would be correct in saying that, yes, but I don't think at any point in our society that women are going to get rid of bras. What I would suggest more would be strengthening those scapular stabilizing muscles, potentially designing different bras that can have different effects and reduce that scapular tilting. There was a study I remember reading that wearing a bra similar to my brand, increases the weight on this muscle by about, I think it was 20 kilograms. I don't remember, I'd have to look back, but the bras in these specific designs that we have in today's society do affect it. So potentially there could be a design that limits that, or I don't know if strapless bras, if we're familiar, if that can affect it differently, but in conclusion, yes, bras do affect it, but I recommend to strengthen and do rehab exercises before we burn the bra.
Hi, this is Brenda. I had a lumpectomy and I had SIS, and I'm wondering, have there been studies to see if scar tissue affects that?
Yeah, so scar tissue, if I can just go back to it. This study that was looking at the scapular kinematics in pre and post unilateral mastectomy, that persistent difference, they think that could be due to scar tissue and other things. So the increases in breast mass can be due to the lymph nodes in the breast tissue or the carcinoma, but the vast majority of increase in that mass is due to lymphedema. But the scar tissue could be a part, and it is one of the proposed mechanisms. So overall, it's not very well understood, but I think that scar tissue would be a contributing factor. There could be other factors, but this is a research project that I'm just taking the first step and seeing how does breast do it. So, yeah.
Hi. Am I next? Okay. My name is Solveig. This may be a really simple question, but because sports bras are by their very nature very controlling everywhere, why did you make that choice? It seems like that would, the very effort of moving around, I mean, there's a good reason why people are controlled in that way, for playing tennis or whatever.
Yeah.
So why would you choose particularly a sports bra?
I chose a sports bra for the fact that compression bras are one of the more common types of bras. There's also encapsulation bras, which encapsulate the breast and hold it in its place in itself and pull it up versus just squeezing everything around. Sorry, not very technical terms. But also due to financial reasons, I had a certain budget, and this type of bra that I had did limit me, and I had to find a cheap one. So the one that I found was like $15 a bra, versus we all know the women in this room, bras can be very expensive at times. So that is another reason that played into it. And that is one of the main limitations of my study, is the type of bra. So I think more research should look into it. But yeah, does that answer it a little bit more?
Hi, this is Ken. I realize I'm getting a long ways from your research, but what about backpacks? People could wear them, I know not as much as you would wear a bra, but they could be a lot heavier. Do you anticipate some effect from that?
I do anticipate some effect from that. I didn't look a ton into backpacks, but what I could think is that it could cause us to stand more hunched. And I did remember reading a study at one point where backpacks do cause our spine posture to be worse. So I could imagine that Subacromial Impingement Syndrome is commonly associated with bad spinal posture as well. So I can imagine wearing a backpack forces us to be more this, because it's pulling us backwards. So weakness in our lower abs to hold backpacks upright and maintain good posture. If we have weakness in that, that can force us to kind of hunch our backs and compensate in that aspect. So I do think that wearing a backpack chronically for a long period of time could lead to that effect, yes.
Hi, I'm Sheila. I'm a little bit confused, so please bear with me. But we started this saying that this impingement was more prevalent in people that had a mastectomy, that had breast cancer and a breast removed. Wouldn't that be less mass in that area than the other breast? So why would the one that was removed be getting the impingement if we're talking about an added mass adding to it?
That is a very good point. I understand your confusion, and it could be the way that I explained it, but the breast cancer survivors, or the increase in mass could be what is causing those alterations in the scapula, and then we receive the mastectomy and we still we saw that reduction in anterior tilt, but we're still seeing a persistent difference. So after removal of the mass, there's still some other factors like the scar tissue that could be playing into it. So it's a combination of both, of having that added mass for a long period of time, of going through that treatment of breast cancer, and then you receive the mastectomy. And after receiving mastectomy, it's my understanding that you have to limit your arm motion for a period of time, which can cause more tightness in the muscles surrounding, which could also be a contributing factor. So I think that it's a lot of things playing into this one thing, where it's not just the added mass, but the added mass, I think, is a contributor. Does that make a little bit more sense? Yes. Yeah.
Hi, thanks for your research. It was really interesting. Now, I was wondering if the uneven mass between one side and the other might cause a problem in the back, the upper back, and the shoulders.
That is a good question. Not really something I thought about specifically until right now, so I could think that it could have an effect. I'm not really sure. I could think that having that added mass on that side could change the way you're moving, but I'm not sure if there's bigger changes with the fact that the one side was cancerous and there's more, like the lymphedema could be creating more mass and whatnot. So that is a very good question and something I would be curious in looking into a little bit more. Sorry I'm not able to answer that more specifically now.
All right, thank you. Okay, good. We do have some things. And Dr. Edinger? Here. This is a certificate and a check from ICL to you. Thank you very much. Thank you. And Dr. I'd raise the cup higher, but I'd write my rotator cuff. You're good. You can. We have something. Thank you. All right, thank you.